I do want to welcome you all to the Q1 2023 provider webinar. My name is Tanya Smith, and I am the moderator for today's webinar. I do ask that you still remain off camera and muted. If you have a question, please use the toolbar across the top and raise your hand, or the other option would be for you to drop your question in the chat. I do believe we will have time to answer some questions along the way, so feel free to ask as many as you need. If we run out of time, I will certainly follow up via email or in the chat as we have our presenters talk. So during today's webinar, we will hear from Melissa, our AVP for Medicaid Operations, on interpreter services, billing, and reporting. I will also have some updates for you on credentialing and website changes, as well as provider outreach efforts from our provider relations team and required education. And then finally, we will hear from Erin on our risk adjustment team on documenting and coding for our Medicare Advantage members. So at this time, Melissa will be sharing the latest updates that she has on our interpreter services and billing. So thanks for joining us, Melissa.
Yeah, thanks for having me. Thank you, Tanya. We just wanted to bring you all an update as to where we're at with interpreter billing and reporting what we've been working on. So as you should know, beginning January 1st, we are open to receiving claims for interpreter services. That was not the case in the past for our contracted providers, but you're now able to bill for interpreter services using the T1013 code, which would have to be included on your medical claims, related medical claims. There are a few provisions that, are really key in carrying out interpreter services and documenting interpreter services. There are penalties attached to providers, and CCOs have a responsibility to collect information related to interpreter services and ensure we're trying to use qualified and certified interpreters to the extent possible. There are penalties attached to us for not doing those things too. So we all need to be paying attention to how we utilize interpreter services. So for the billing, I believe we have a handle on that, being able to accept claims and reimburse you all for interpreter services. We are working on reporting though, and that's what we wanted to bring to you all. If we go to the next slide, we are working on capturing information that OHA is requiring that is not able to be documented on a claim. And these are things such as the interpreter's name and certification number, the mode of interpretation, so whether it's phone or telephonic or video, whether or not there was a proficiency tested provider providing interpretation during the visit, and then also member refusals. And there's about 4 different reasons that need to be captured. So what we're doing now, and unfortunately, this is another administrative process. I think, we all struggle when additional information is needed and there's no automated way that's integrated into the things we do every day, but those result in some administrative burden. And what we are trying to do, though, is develop an interpreter services data form, so you could go in and document those interpretation visits and the additional information that OHA is requiring. We are going to be putting that in the provider portal so that you all can report quarterly. You can go in there and individually mark those, enter those data components, but quarterly we can go in and pull that information and report back to OHA. We will be providing more information on this and offering training and guidance, and we can help with workflows as necessary as well. But that's where we're at this time, so expect more information in the next few months.
Thanks so much, Melissa. Do any of you have questions on that at this time? We will, of course, continue to update you as we know more, and of course, try to make your lives as easy as possible. We really do understand and appreciate the administrative burdens that this is all causing you. So thank you for all that you do. And thank you, Melissa, for this information.
Thank you so much.
Okay, at this time, I'm going to go ahead and provide you some updates related to some credentialing. I know this is an ongoing project that we've had coming, and we're excited to say that as of 1/1/2023, SHP and IHN will now be allowing claims for covered services to our members during that credentialing period. We do ask that you not bill us for these services until after you have received your credentialing approval. Any claims that we receive prior to that will be denied. So please hold off sending those in until after you receive that letter from credentialing, letting you know that that provider has been approved. Reimbursement is going to start on the day that that credentialing department receives a complete application, or on the effective date of the contract, whichever is later. So please make sure as you're completing those applications that you're marking everything initially in each page, making sure that you've dotted your I's and crossed your T's. Make sure that you're including any documentation that is required, and then make sure that if they ask for additional questions, that you get that returned back to them as quickly as possible. That's going to, of course, keep the application complete, which is when your time frame will start for reimbursement. The credentialing process does take up to 90 days, so we ask that you're patient while our credentialing team is processing your application. And if they do need additional information from you, they will reach out to the contact person that is on the application directly. So there's really no need to call in unless you have a specific question that doesn't pertain to the timeframes. So another great change that has happened is that as of April 23rd, 2023, the OHA has updated their form, and we do require that you use that newest credentialing application form. Great thing about this form is it is fillable, and we will have it posted on our website, and it is also available on OHA's website. So please make sure you download the correct form, the most current form, and that you're using that when you're submitting those forms to us. If you submit an incorrect form, it will be rejected and sent back to you, and that will delay the process. For the offices that work with E&M codes, we want to make sure that you know that as of 5/1/2023, SHP and IHN-CCO will be following guidelines that are set forth by CMS rather than AMA regarding these prolonged codes. There is one exception to this, and that is for the code 99418. We will still be allowing that AMA code until OHA can get their G codes on the prioritized list. The next slide is going to provide you some codes that are effective and what is appropriate to bill based on the dates. So please make sure you are following the appropriate CMS guidelines effective May 1st. As this new year is upon us, we are going to continue our timely access surveys. OHA does require that we as a health plan monitor the timeliness for our Medicaid population. OAR does have some specific time guidelines and timeframes for you to meet based on the prioritization of these patients. So please make sure you're going out to the OAR 410-141-3500 and taking a look at what those timeframes are. We will be randomly selecting our behavioral health and physical health providers to take this survey. If you are selected, we will be emailing you the survey from our SHP provider at samhealth.org email group. So please keep an eye out for that. If you receive the survey, you will have 3 weeks to complete that in order to maintain the timeframes. Once that 3 weeks is up, the survey will be closed and you will be considered non-compliant in that survey and be added to a follow-up survey. So please make sure you're keeping an eye out for that and getting that turned back into us. Another required education that we have is our special needs model of care training. And this is a CMS required training and is required for all of our contracted providers that are contracted with us for both Advantage and IHN-CCO. This is a requirement upon contracting directly and then also annually thereafter. It is also required for any of our non-contracted providers that routinely see this special needs population. All of our training slides are on our website, so I encourage you to notify your providers that fall into this category and ask them to please take the special needs training and take the attestation. I will also be contacting a lot of the provider offices just to provide them the link directly. And the other option would be, if you're interested, we can do the training before or after work, during work at a team staff meeting, and we can do the attestation as a group. I can send that to your office. Also, if you as an office manager or staff would like to review the slides with your providers and then just attest that you will do that on your own. Finally, we have some great changes coming to our website. We have taken a lot of feedback from all of our offices, which we greatly appreciate. And we are hoping to get these changes completed by the end of Q2. We're working to move our resources to a main page and remove the layers that our offices have to go through in order to locate the information that they're looking for. So hopefully you'll be able to just click on your specialty and find the necessary links in one area that will be applicable to what you need as a provider. As of today, we do have some things in the works. We're going to be adding a dental provider page, traditional healthcare workers, and then a page for our physical health providers. We have also made some great changes. We've added a frequently asked questions regarding our Samaritan Advantage Rewards and Incentive Program, and that's already posted as of yesterday. So please feel free to go check that one out. We also have a No Surprises at Dispute claim tab that will be coming soon. And then we have our PT, OT, ST frequently asked questions. We understand that our offices struggled quite a bit with the decision to add prior authorization requirements for those fields the beginning this year. So please make sure you take a look at that. If you have questions, you can always reach out to our SHP provider email group and we can help you further. And then finally, some of our more recent changes that we've made would be to add a specific behavioral health page. And within that behavioral health page is specific information on reimbursement changes for this year, as well as our specific measure and outcomes tracking system, also known as MOTS. So for those of you in that specialty, please make sure you take a look and see what's there. Also, if you have additional information that you feel would be beneficial there, please let us know, because we do want to make sure that our websites are providing you the information that your offices need, rather than having to do so much work to dig through them. And then finally, another recent change we added was our risk adjustment tab. And this is for Medicare Advantage plans and currently located on our resources tab. This is going to be really great information for you to follow up on as well after we hear from our next presenter, Erin, who is here to provide us information on documenting and coding for risk adjustment. So at this time, if you don't have any questions, I'm going to go ahead and introduce you to Erin. If you do have questions, again, please drop them in the chat or raise your hand and I'll call upon you.
So anyway, so I'm Erin, the risk adjustment analyst at Samaritan, and I'm not familiar with any names, so I was wondering if maybe I could get like a show of hands for anyone that deals with risk adjustment or knows about risk adjustment, or you can even come off the mic and say what you do if you don't mind. Or if anyone does coding or is a coder for the office.
Christina works for Corvallis Family Medicine and CPC. I'm not sure what that is, but
Okay, I know. Yeah, I don't either. Okay, well,
so
go ahead. Oh, go ahead.
yeah. So for those of you that don't know a lot about this, it's still great information for you to share with your offices and to let them know that this is recorded, and please have them take a look afterwards, just so that they can capture the great information Erin's going to share today.
Thank you. And these are the other people in my department that work on risk adjustment, which is Wade Penner, the manager, me, and Christy Thomas, the risk adjustment coordinator. And then we're going to go over just kind of risk adjustment background, a little bit of the HCC model, the formula, the provider's role in risk adjustment, and then some documentation and coding guidelines that apply to risk adjustment. And then we'll cover the some of the HCC disease groups in the model. And the purpose of today's presentation is just to provide an overview of Medicare risk adjustment and best practices for quality documentation and coding, with the goal being to ensure accurate reporting of conditions that impact risk adjustment. And differences in beneficiaries' health status have a significant influence on healthcare use and spending. We use risk scores to help understand those differences, which are also used to adjust payments to Medicare Advantage plans, which account for the differences in the health status among enrollees. Plans with enrollees with a higher than average risk score are expected to incur higher than average costs. And the risk scores are in part based on diagnosis codes that are then grouped into related disease categories known as I can never say this word, sorry, hierarchical condition categories, or HCCs.
I think you did great.
And the HCC-based payment risk scores are actuarial estimates regarding how a fee-for-service beneficiary spending compares to the overall average for the entire Medicare population. And they set the average risk score at 1.0 for the overall all Medicare population. So you can compare the individual risk score to that. So one of 2.0 means that they're expected to incur twice the overall average, and vice versa. And there's different models that address different program costs. So there's a Part C model, the HCCs, and a Part D model, which are RxHCCs. And the model is prospective. So diagnosis is in 1 year, used to predict costs in the following year. So for 2023 right now, we're being paid based on dates of service in 2022. And they also are additive. So unrelated disease categories will accumulate, and hierarchies are used thank you, hierarchies to reflect the most severe and costly category of a condition. And then there's interactions included, which accounts for the increased cost of certain conditions occurring together. So there's a handful of conditions. When you have both of them, you get an added amount for those two conditions, like congestive heart failure and diabetes, CHF, and COPD or renal failure. And the model is made up of demographic and health status. And the demographic factors would be things like age and gender, Medicare disabled status, and the health status is from ICD-10 diagnoses on claims. And those predicted costs are converted into relative factors or weight that are used to calculate the risk score. And the source of the diagnosis has come from inpatient and outpatient facility claims, professional claims. It has to be a physician or a clinically trained non-physician, and it must be a face-to-face encounter. It can also be telehealth if there's both the video and audio components included. And a big thing about the model is you have to reconfirm the chronic conditions every year. So on January 1st, everybody goes to 0 health status, it resets, and the conditions must be assessed again and reported on an encounter. And the risk score formula. So there's a relative factor that will contribute to the patient's risk score. It's also sometimes called a coefficient, which varies by the demographic group. So there's different coefficients for people that are disabled, dually eligible, and living in an institution. And the sum of those factors equals the raw risk score. So you get a factor for your gender and age, and then on this example, there's a CHF and diabetes with complications, and then the interaction for diabetes and CHF. And the total of the sum of that equals the total raw risk score, which each one of those coefficients shows the incremental predicted expenditures associated with those components. And then CMS applies some adjustments to that raw risk score. They apply a normalization factor, which is used to keep the average risk score at 1.0, and a coding pattern adjustment to account for the differences in coding between fee-for-service and Medicare Advantage organizations. And then the result is the payment risk score. And that payment risk score is then multiplied times the what's called a bid amount. For the it goes by county, and then you get the payment risk score, and that's for a monthly payment. In this example, is $862. And just want to note that in the payment risk score, just a change of 0.1 can add up to be millions of dollars.
So coding is very important in documenting.
Yeah. And next slide. And so the provider's role. So you probably know that new models of payment are increasingly shifting financial risk to providers, but many providers aren't aware of how essential accurate coding is under these models to characterize risk, enhance shared savings, and provide patient-centered care. And risk adjustment utilizes a patient's diagnosis codes that are reported on an encounter to determine the person's disease burden and expected costs. So accurate capture of their health status and complexity is essential. Documentation that's not clear and sufficient cannot be used to determine that patient's true complexity.
Right.
But that's fine. And so the ICD-10 code data communicates the health status of your patients. Comorbidities impacting your decision making and the patient's outcome are explained using ICD-10 terms. So the importance of understanding risk adjustment diagnosis coding is essential for clinicians to communicate the disease burden of their patient population to payers. And so an engaged partnership between provider and health plan is vital to bringing valuable benefits to enrollees. The health plan will use diagnosis codes that are on claims to identify programs that are needed, and then more specifically who needs them. And also, the more successful the risk adjustment program is, the more benefits we can offer to enrollees, such as dental, transportation, vision hardware, and over-the-counter. And here are just a couple graphs just showing the risk score trend by primary care physician group for 2021, 2022, and 2023. And then I have one for the recapture rates, or the reconfirming those chronic conditions for the last 3 years. And so that amount is the percentage of chronic conditions that were recaptured for those PCP groups.
And just to confirm, the recapturing is done through the documentation and coding for the next year then? Or is the recapturing based on the fact that the patient still had that diagnosis?
Yeah, so we send out to the providers, or some of them, all their chronic conditions for them to do pre-visit or before appointments to look those over to make sure that they capture them again for that year. So that's what that rate is from. So right now we're sending out, 2023 conditions that were reported in 2022 that we need to recapture for this year that will be paid for next year.
Perfect. Thank you.
And then that's fine. And this section is on kind of just documentation and coding. So if you have coding policies, you want to make sure to include some information on risk adjustment specific guidelines that your office has. And some providers I've heard confuse the E&M leveling rules with the guidelines for selecting a diagnosis code. So the CPT definition of problem addressed is not an ICD-10 rule for diagnosis coding. I believe in that rule, it says, you can't consider the problem in your, it must be addressed at the visit to consider it in which level of service you're going to bill, but that doesn't apply for the diagnosis codes. You should code all documented conditions which coexist at the time of visit that require effect patient care or treatment, but do not code conditions which no longer exist. And that's from the diagnosis guidelines. And here's just some other ones for outpatient. for codes that describe symptoms and signs are used when a diagnosis has not been established. You can't report probable, suspected, rule out conditions. And then the previously mentioned guideline of code all documented conditions that coexist at the time of visit that require affect patient care, treatment, or management, and ones that no longer exist to not code. And then here's some risk adjustment topics, or the importance for risk adjustment, and a reference for the official guideline. And I'm not going to read this word for word, but like for malignancies, cancers that have been eradicated and are no longer under treatment won't be an HCC, but malignancy currently receiving active treatment is. The importance of the correctly assigning the 7th character, which makes a difference. The initial encounter would be an HCC sometimes, and subsequent ones, though, for routine healing is not. And code specificity is a big one. So if it's not, if conditions aren't specified, they may not map to an HCC, such as major depressive disorder unspecified. But if it's specified as mild single episode, it would be an HCC. Same with kidney disease unspecified, doesn't map to an HCC, but if the stage is specified, then it would. And hepatitis, without saying chronic, would not be an HCC. And then sometimes it's important, or sometimes there'll be two different HCCs for the etiology and manifestation. So make sure to code for both if appropriate, and to follow the excludes notes. You can sometimes you could report an incorrect HCC if you don't follow the excludes notes. And the with concept is really important in code selection and makes a difference in HCC coding. So it's for complicated related diseases. And if the conditions are linked in the index under the main term or in the tabular listing, you can assume a causal relationship between the two without the provider linking it in the medical record. You can assume that those two are linked and code it like that, unless they specifically say they are not related. And so it assigns combination codes such as diabetes with chronic kidney disease and manifestations such as angina with spasm.
Ooh, sorry.
No, that was perfect. and here's some examples of the with terminology, I guess, for like under diabetes, how it has different codes when the other condition is with it, substance use with substance-induced disorders, hypertension with heart failure, and if it's not specifically, if the condition isn't under one of those with subterms, then the provider must specifically link them in the documentation to code them as such. And then this is just an example of a patient with hypertension, diabetes, and CKD, CHF. On the left isn't using the with diagnosis, and on the right is, which ends up being more, or the total risk score is more on the right side because of the type 2 diabetes with CKD. It maps to an HCC of 18, which in the hierarchies, it's higher than HCC 19 for the uncomplicated diabetes. And on the right side, HCC 85 is on CHF and also the hypertensive heart and CKD. So one of those cancels out. You only get the credit for it one time. And just some quick documentation reminders that each medical record must include the patient's name, date of birth, date of service, provider signature, including credentials, and the date signed for electronic signatures. And for amendments, they should be completed as soon after the original note as possible and need to be timely and have the current date and time, reason, and be signed by the person making the addendum. And meet and tamper, those are two acronyms that a lot of people in the industry use to determine whether or not a condition is supported in the medical record. And they stand for meet, monitor, evaluation, assessment, and treatment. They're not CMS concepts or requirements, but just useful tools to identify documentation that supports coding accuracy. And the next slide has a little bit more information on those, like what is under monitor. If you see the condition and there is a medication, then you know monitor meet criteria was met, and you can say that that's supported. And so common issues for risk adjustment coding, I work with vendors to do retrospective chart reviews, and these are some of the common issues that we see with having to delete diagnoses with CMS because they're not supported in the medical record, because they're only in the problem list, or they're in past medical history, the medication isn't linked, or it's audio only telehealth. And so history of, in ICD-10, the term history of means that the condition no longer exists and is not being treated or addressed, which can be different than what the provider considers history of. So we see a lot of like history of COPD, and then there's a medication that they're taking for COPD. So history of wouldn't really be the right terminology to use, but there's errors made in one of two ways on the history of. A past condition is coded or documented as active, or it's documented as history of when that condition is still active. And there are some conditions, past conditions that would presently be quiescent, such as some cancers, depression, alcohol and drug dependence. And these should be considered documenting as in remission because they're often monitored and may require maintenance treatment. So only document history of for illnesses that no longer exist and are not being treated or assessed. And then problemless and past medical history. One of the few guidelines that CMS has given us is that you can't code from the problem list. It must be documented elsewhere in the record and show that it was assessed, managed, or treated for it to be reported. And with past medical history, kind of the same thing. There has to be something that says how it was addressed or treated or affects that data service. And unlinked medications is probably the biggest one. So you have to link the medication to the diagnosis in order to support a condition's active status. Coders aren't allowed to make excuse me, assumptions that a medication is used to treat a specific diagnosis. So in this example below, diagnosis Z79.4 was used for long-term current use of insulin, but it's not supported in the medical record, even though it's obvious that they're taking, in the medications they have insulin, and the problem list they have diabetes, but it's not linked. And in the assessment plan, it's not mentioned down there. And telehealth. So CMS requires both audio and video components be present in order for the diagnosis to be used for risk adjustment purposes. And that's just for Medicare Advantage. I don't know if anybody ever deals with the ACA commercial risk adjustment plan, but they do allow audio only to be counted for risk adjustment in that risk adjustment plan. And so what clinicians need to remember is just mostly to pay attention to the ICD-10 guideline to code all documented conditions which coexist at the time of visit that requires or affects patient care or treatment. Also add to the assessment and the claim conditions evaluated and treated at the encounter, and chronic conditions that affect the treatment of an acute problem. Avoid using unspecified if there's a manifestation or complication, and if there's a diagnosis that applies to a patient that describes a complication or manifestation, to use it, and make sure for every medication prescribed that there's a diagnosis listed and it's specified which condition the medication is being prescribed for. And so document at least once a year chronic conditions that require ongoing treatment and monitoring, active status conditions such as ostomies and amputations, historic conditions that may no longer exist yet have the potential for reoccurrence requiring continued monitoring, and all conditions that impact patient care, treatment, or management. Each condition addressed during the encounter should include a statement indicating the impact to patient care, treatment, or management, but at a minimum include a brief statement that updates the status of each diagnosis. Next. And then disease groups. Since nobody seems to be very familiar with the current model, I won't go into much explanation, but there is a proposed model that we'll find out in April whether or not that's going to go into effect that has major revisions to it. They're removing groups like protein calorie malnutrition, angina pectoris, arteriosclerosis of arteries with intermittent claudication, and a whole bunch of other ones. So this is kind of based on the proposed model that is affecting 2023 dates of service, but will be used in 2024. And we'll just go over a few of them, and then I just included what conditions kind of in general are under each group. So in the infectious disease group, there was an update to the HIV coding in 2022 to use B20 when a patient's taking antiretroviral medications, and you use the Z21 when they don't have any symptoms, but they are documented as having being HIV positive or having known HIV or HIV test positive or something similar. And then in the neoplasm disease group, just some reminders to use a code for malignant neoplasm if the patient has evidence of the disease or is receiving treatment. But if they're not, you need to use the personal history of the cancer. There are some leukemias and lymphomas that should be coded and documented as in remission, and those are coded with the active cancer disease code. And then hormone treatment, if that's considered receiving treatment for the cancer, and you can continue using the malignant neoplasm code during hormone treatment. And diabetes with chronic complications, so that in most cases there's a combination code that'll identify the type of diabetes and the complication. If you use the other specified complication code, you also have to add a code for the complication. And just a reminder to refer to the subterm with that links the two conditions in the ICD-10. And multiple diabetes codes are sometimes required to capture all the complications of the patient's diabetes. And you can't just state uncontrolled diabetes and code it as hyperglycemia. It has to be stated as with hyperglycemia or hypoglycemia, or it will default to the uncomplicated diabetes diagnosis. And then the metabolic disease group is morbid obesity. The BMI value is greater than 40, and the diagnosis codes E6601 and E662 map to an HCC in the CMS model. But the provider must provide documentation of the clinical condition. You can't report the BMI value as a standalone code. It has to have the clinical condition documented by the provider. And there's no coding guidance to automatically assign the morbid obesity. For someone who's under 40, the provider would have to state morbid obesity. And a BMI of greater than 40 doesn't mean to automatically code morbid obesity unless the provider states that. And dementias in the cognitive disease groups, which that one you just have to remember to first code for the underlying physiological condition, if appropriate, the Alzheimer's and Parkinson's, and then all of the codes have one for either with behavioral disturbance or without behavioral disturbance. And I think there's actually even more in the 2023 update, another digit on those that go into more detail. And substance use disorders. So the HCC groups in here are drug and alcohol use with psychotic complications, moderate, severe, mild, uncomplicated drug use disorders, and alcohol use disorders that are moderate, severe, or with a specified non-psychotic complication. And the DSM is outlines the diagnostic criteria for these conditions. But ICD-10 will code mild, the 2 to 3 criteria in the DSM to abuse, and moderate or severe will code to dependence in ICD-10. And cerebrovascular is your stroke, late effects of CVA, the hemiplegia, hemiparesis, and monoplegia. And one common error is reporting the stroke in an outpatient setting, like after they've had the stroke, and they're being seen for a follow-up. That's an acute code and usually just billed in the inpatient setting. So unless there is late effects, the personal history is the right code to use. And the residual effects are in category I69 for the sequela of the CVA, and there's no time limit on reporting those, the late effects. And then the kidney disease group includes just the stage 3, stage 4, and stage 5. Be sure if there's hypertension to use the combination code. And then the dialysis. Dialysis has some HCC codes too of either they're on dialysis or they aren't doing dialysis. next one. And then the psychiatric disease groups includes your schizophrenia, personality disorders, bipolar disorders, and major depression. And then the heart disease group is your heart transplant, heart failure, MI, unstable angina, and then specified heart arrhythmias. And lung disease group is your COPD, some pneumonias, cystic fibrosis, and some others. And the liver disease, the cirrhosis of liver, chronic hepatitis, chronic liver failure, and end-stage liver disorders are in this group. And the musculoskeletal has rheumatoid arthritis and systemic lupus erythematosus and some others. And the neurological disease group has your cerebral palsy, muscular dystrophy, MS, Parkinson's, seizure disorders, and others. And the vascular disease group includes DVT, pulmonary embolism, and vascular disease with complications. And then there's an amputation transplant openings disease group. So amputation status, lower limb amputation complications, the transplant disease group, stem cell, including bone marrow transplant status, and then artificial openings for feeding or elimination. And thank you. And here's our email address. If anybody wants to ask us a question or wants more information or anything, you can send an email to that address or our individual ones up in the beginning. And then there's also an appendix and additional resources to the 10 principles of risk adjustment that CMS uses. Currently the model change that's going to happen next year is addressing the number 10, exclude the discretionary diagnostic categories. And then I think I just did another summary of the characteristics of the HCC models, of the HCC model, yeah. And yep, one more. And then some examples of the MEAT approach you can read through. And then I think the last one is just some additional resources. So the CMS guidance for risk adjustment and also where you could find mappings of diagnosis to HCC and some other information on Medicare's website.
We have one question. Sam?
Go ahead.
Hi, can you hear me?
Yes.
Good morning, everyone. I'm Sam Milstein. I'm a osteopathic physician, and I own Ridgeway Health out in Sweet Home. A couple of questions. So one, I want to put out a resource. I thank you for your slides. They were a great introduction to HCC risk code and risk capture. Regents also put out a nice YouTube video series that was an excellent resource, and that's how I learned HCC risk code capture as residents at Samaritan. I did want to ask if there was any opportunity or interest on Samaritan Health Plan side, similar to how external providers, probably internal providers, get care gap metrics report cards. If that there might be a star granted kickback or some sort of ethical legal conflict of interest there that I don't know of, but it would be a wonderful thing to be able to work together to capture additional HCC risk scores by providing tips, suggestions, or missed opportunities or opportunities for capture. And I don't know if there was bandwidth, desire, or financial incentive to doing so.
For sure, we can provide that information for our Medicare Advantage members. We do that for primary care physician offices, or but some of them, not all of them. And I missed where are you at?
Ridgeway Health. So we just started up primary care January 16th, and we operate urgent care, primary care, and occupational medicine. Okay.
Yeah, if you want to either email me or put your email in the chat, I can connect with you afterwards and we can discuss what would be helpful, for sure.
No, I emailed Denise. I don't know if I got forwarded. But yeah, that would be a great opportunity. I mean, even if there's this can get as complex as we all want it, right?
Right.
But focusing on, I think focusing on the best return on time and work investment, and
Mhm.
saying, hey, these are the biggest. This is the top 10 list, the biggest bang for the buck, most approachable and easiest things to go for. And remember, I think for providers, we're simple people. That would be a tremendous benefit if you gave us 10 things to remember, and that addressed that captures 70% of it. Now instead of fighting for 100% improvement,
Mhm.
now we only have to do a 10% effort in order to get a 30% return on time investment.
Yeah, I totally agree with you. Yeah, that'd be great. And we would love to work with you to provide that information.
I can make
Let's do
sure
it.
you both get connected. I have Sam Milstein's contact information, so I'll make sure that happens.
Thank you.
Thank you, Tanya.
Does
You're
anybody-
saying this always.
Thanks. Anybody else have any other questions or comments? I know it's a lot of information for especially those that aren't coders, but I appreciate those of you that are willing to, give this on. And then if anyone does want a copy of the slide deck, please make sure that you drop your email in the chat, and I will make sure I send those to them. Otherwise, the recording will be available within a week or so, so you guys can review it as well. So,
Can I interrupt? Tanya, I have one more thing. And I'm
absolutely.
sorry for being late. I don't know if it was covered, but I heard that there was, with the coding for translator services.
Yes, interpreter services.
Yes, sorry, interpreter services. That there was a change to the policy and workflow to that from prior.
So I don't know that there's been a change. Melissa, are you still on here? Melissa basically just provided some updates. We're going to continue to allow for billing, and we're going to work to get you the documentation in Provider Connect, where you can upload the required documents that OHA needs.
What are those?
So,
what documents does it require?
There's a whole slew of, there's a whole slew of information, one of which was the certified provider's name. There were a bunch of things. So as they get that built in One Health Port, that will be available for our providers to use that source. I will send you the slides, and there are some links to some OHA websites that will probably provide you some of those requirements.
Is it like a one-time form, like, hey, this is the service provider that we use?
No, I believe it's going to be for every code you bill for. So each time you bill for that code, you need to be able to provide the required documentation as to who the certified interpreter was. There's also some requirements if a member denies or declines interpreter services. So there were a bunch of things that were mentioned.
Is that going to be utilized for quality measure attestation?
That I don't know. I'm happy to connect you with Melissa Isoveran. She's our AVP for the Medicaid program. She might be a better resource for you to answer those questions.
Okay, because I know it's an OHP quality metric. I know that there's funding attached to it, and if there's an incentive and it's included in a quality metric bonus pool for, I'm an external provider, that it would only seem fair that if we're doing the extra work to fill out a form to attest to a numerator and denominator, that we would also share in that pool. I think that would only be fair, similar to other quality metrics.
Okay, I'll connect you with Melissa, and then you guys can see how that might work.
Sounds good. Just because as for simple fee for service, it's on the standard OHA fee schedule. It has been since I was a resident at Samaritan, and I use the same interpreter service that Samaritan uses. So
okay,
yeah,
perfect. I'll make sure I connect you two after this as well.
Thank you.
You're welcome. Any other questions or comments? We have about 4 minutes left. All right. Well, thank you very much, Erin, for this great information. I appreciate all that you provided. And if you have additional questions, please make sure you reach out to Erin directly. As we look to the next slide, I do want to make sure you have our contact information. If you have any other questions specific to us or the provider relations person that is yours, please feel free to reach out to them directly, or you can email our group at shpprovider@samhealth.org. So again, thank you very much for your time. I hope you have a wonderful rest of the week. And if you need anything, let me know. I will make sure I get those slides sent out to those that ask for them. Thank you and have a good day.
Thank you, Tanya. You're the best.
Thanks. Appreciate it. Bye.